All right, so we are recording today's lecture. Again, what we're going to do is because it's 75% of your exam will be EKG strips. There will also be one, maybe two bonus questions to come into play there, and they'll all have to deal with cardiology. Okay, so as we're going to go through this, let's just kind of take a look. Joe, we're going to start with you. All right, and we'll just go kind of zigzag back and forth as we're moving through. So, Joe, tell me what that rhythm strip is, and as we're going through, if you want to go through the 5 steps verbally, I'm okay with that. If you want to go through them mentally and check them off and then tell me the answer, I'm okay with that as well.
It has a rate of 80, and that's just the first thing that I noticed because 2 of them are outside of that.
Good catch. Good catch.
Otherwise, it would be a rate of 100. The P waves are upright, and you can notice them all. It looks about a normal PR interval. There's a QRS with every P wave, and vice versa. QRS looks about right. T wave looks a little long, but that doesn't really affect anything.
No.
To my knowledge, it just looks different.
Okay.
I'm gonna go with a normal sinus rhythm.
Okay, good. That's exactly what it is. Good start. Now, again, Joe mentioned in here that the T wave looks a little weird. Now, one of the things just to kind of hold in the back of your brain as you get ready to move into the advanced sequence, when you see T waves that are weird like this, you want to begin thinking, Blake, may be a problem with potassium. So the T wave begins to get really large when we have hyperkalemia or hypokalemia, high or low potassium. Now, right now, for the most part, when we're working with patients, CC, you and I are not going to be able to measure electrolytes. That will change, okay? Probably not as quickly as you will see with patients that you'll be giving blood to in trauma, but there are little handheld devices. I have one of them down in my office that will allow you to literally run labs on your patient. And you guys, before your career ends, you'll be doing this as part of your scope of practice. Okay, good job, Joe. Anybody have a question as to why this is normal sinus rhythm? Hey, Bella, welcome.
Hi.
Okay, Chase, next up.
It's gonna be SVT.
Say it again.
SVT.
SVT, you're exactly right. So here's the thing we're looking at. So help me understand what's the difference between SVT and sinus tach?
SVT's faster.
Perfect. And this is for anybody. What's the difference between SVT and VTAC?
VTAC is like bizarre looking where it's coming from the ventricle.
You are so wonderful. Yeah. What's bizarre looking?
The QRS complex.
Perfect. Perfect. Yeah. So that's the kind of thing that you're going to look at. Now, guys, keep in mind, again, as you continue your paramedic career, sometimes you will have rhythms that you'll look at and you go, that kind of looks like SVT, but then again, it kind of looks like VTAC. I'll give you some strategies and some medicine, adenosine, that will help you to narrow that down to help you to identify which is going to be which. Good. Yes, Joe.
So I did ride time about 2 weeks ago or so.
Okay.
One of the people there, he was 60s or so.
All right.
And he took a bunch of his pills the night before, so he just wanted to get checked up. But we took him to the VA in Lexington, and he had a heart rate of like 180. And the paramedic on board couldn't tell if it was SVT or AFib. So he gave him adenosine, and it brought it down, and then it shot right back up.
Okay.
And then he gave him another dose, and it brought it down, and it shot right back up. So, since it's a monitor, how would you say is like the best way to tell the difference between SVT and AFib?
Well, again, that's a great question. And for those of you that are listening to the recording, Joe asked, how can you tell the difference between SVT and AFib, that is what we call RVR, rapid ventricular response. One of the tricky things with AFib that's really fast is that the faster the rhythm, the more regular it gets. And obviously, we know with this, we can make an argument that I think maybe we see a P wave up there. But again, as if you've got a patient with a heart rate of 180, you're probably not going to see a P wave as well. Now, let me ask you a question. Was he thinking SVT versus AFib or SVT versus VTAC?
So kind of, because like the QRS looked normal, because I could see the monitor from where I was sitting, so
Okay.
it was fine. And he gave him adenosine, so he kind of figured, like even after we dropped him off and everything, we were going back. He mentioned that he couldn't tell if it was SVT or AFib just because it was so.
So how slow did it slow down when he gave the
It
adenosine?
dropped to about 50.
Okay.
It dropped majorly and then it just shot right back.
So one of the things that you can do, and many times, ladies and gentlemen, you're going to be in that same situation. You're going to look at it and you're going to go, looks like this. Looks like this. Okay. So again, if your patient is symptomatic, and I would suspect with a heart rate of 180, your patient probably had some symptoms.
He looked fine. He said he was fine.
Interesting.
We really couldn't tell anything was wrong except, like, if we didn't have that monitor,
Oh, yeah.
he would just be fine.
So what you would do is you would look when the heart rate slows down. Okay, so was the heart rate regular or irregular when it slowed down?
I didn't see that.
Okay, so if it was regular when it slowed down into 50s, that's probably going to be SVT. But if it was irregular when it slowed down, it's probably going to be AFib. But now here's the thing to kind of, again, keep in the back of your brain. It won't be on your exam. You want to be really, really careful about giving adenosine to a patient that you know has AFib, because that can result in really bad outcomes. Good commentary. Juju, this one's yours, okay? And you'll see some like this where it's not the rhythm, but it's the rules.
Well, in the PR interval, it says that it progressively lengthens until a P wave isn't conducted. That makes me think it is first degree heart block. But it says that the atrial rhythm is regular, so I'm trying to figure out the underlying rhythm.
Okay, so now again, make sure you understand the explanation of not conducted. You got a P wave, but then you don't have a QRS. Okay, and then you've got a pause that follows the drop to QRS. Do you see that in first degree block? What's the hallmark? Somebody help her out. And this is okay. What's the hallmark of first degree heart block?
Oh wait, no. Because okay, first degree they're all the same. It's second degree type 1.
Look at that. Look at that.
That's what I don't know.
It's okay. It's dead weak. It's in the morning. You're okay. All right. You recovered. All right. And so again, not only do I want you to look at rhythm strips like that, I also want you to know the rules, because this is how you're going to identify this. Very good recovery. Good recovery. All right, Teray, this one's yours. See those gears working. That's good. That's good. So what do you think?
Is it functional rhythm?
Let me ask you, why would you call it a junctional rhythm? Do you see P waves?
I see two of them that's inverted.
Two of them as what?
That's inverted.
Ah, what else do you see? Okay, the QRS is fine. What else does anybody else see anything different, Bella?
I see that there's 3 different looking P waves.
Which would make this?
Well, since it's a normal rate, it would be a wandering atrial pacemaker.
Yeah. So we see as we're going through here, again, this is why on your 6-second strip, like you want to look at each complex, okay? So we look at our P wave here. So we got, that's our standard. And then we look at this one. It's a little different, but it's close enough to be counted as right. So there's one P wave. That one's close enough. Here's our inverted. Very good. You notice that it was inverted. Now we got 2 that are different. And then we come over here, and this one could be similar to that one. Okay, we see that. And then we come over here, and we've got no P wave whatsoever. Okay. So again, somebody explain to me, what is wandering atrial pacemaker? What's actually happening?
There are different spots in the atria firing.
Perfect. Yeah. So literally, the atria is taking a walk. Okay, as far as different spots that are firing up in the atria. Okay. So keep in mind that the junction is actually, Tanner, located within the atria. That's why we see this inverted P wave here. That's why we don't see a P wave over here, because it's coming all the way down into the junction. Okay. Any questions on why this is WAP? All right. Blake, this one is yours.
So it's saying that there's no P waves, and the quivering is really catching my quivering of the ventricles, so it'll probably be her.
Yeah, good. Very, very good. Can you have a pulse with VFib? Not a trick question. Can you have a pulse with true VFib? No. The heart is just kind of sitting there shaking. There's no organized activity that's going on. What's the treatment for VFib? Shock. Okay, good. Tanner?
P waves look a little odd to me.
Do they look similar as you're going across, though?
They look similar enough, but it's like the little differences that are kind of giving me a hard time. Like this one just flattens out, and that one is a full spike.
So now, again, keep in mind there's a couple things going on here. What is your rate of this particular rhythm? A 6-second strip.
Say about 130.
Okay, so we got 130. Again, the other thing that you've got going on with this dude right here is that what's probably occurring with this particular patient to get this movement up and down of the rhythm. He's probably moving, yeah. So that's probably having an impact on the very minute changes you're seeing in the P waves. Now, again, if you're thinking WAP or MAT, you got to have some drastic changes in the P wave. Because remember, when we went back to the other WAP that we had earlier, those first 2 I said, yeah, they look a little bit different, but they're close enough. So I would tell you that the P waves there, even though they're peaked, they look different, maybe than rounded. They're
It's not
close
bad.
enough to not be in the MAT category.
I'd probably just say sinus tag.
This is why I like being around smart people. Okay, so yeah, it's a sinus tac. You're exactly right. If we have a patient that's complaining of symptoms, remember with sinus tac we treat the underlying causes. Okay, if it's anxiety, we try to help them calm down. If it's increased caffeine take, we counsel them to maybe lay off some of the coffee or the energy drinks or whatever it is that we take internally to help us to make it through the day. So again, sinus tac, excellent. So you see, name that tune. Not idioventricular. Anybody know?
Is it pacemaker?
Is it well?
Pacemaker because of spice?
There you go.
Okay.
All right.
That's my second guess. But
Yeah.
sure.
Yeah. So yeah, you're exactly right. So you got to look at the whole rhythm. Now, if we didn't have these pacemaker spikes, and if we didn't have a T wave, idioventricular will only have a wide, bizarre looking QRS. So you won't see the pacemaker spike in front, and in idioventricular, often, not always, you won't see this well defined T wave. But if there was no pacemaker spike in front and you called it idioventricular, I'd give that to you. But again, this is a pacemaker rhythm. Now, we talked about this on Monday. If you wanted bonus points for this, what would you tell me?
It's a single chamber?
It's a what? No, go ahead.
It's a single chamber
How do you know?
because there's only one spike.
Yeah. So there's only one spike. So if you were to say, oh, well, that's a dual chamber, you don't get the extra points, but it's not going to hurt you. Okay. So that's a single chamber pacemaker rhythm. Good. Very good. Bella? Now, I want to tell you something. Disregard this right here because I need to edit this. This should be down to 140, not 160, because that may confuse you just a little bit.
Is this just sinus tachycardia?
Yep. Just sinus tachycardia. Joe.
What's the significance of positive and lead two? Or is that just there?
That's some additional information that I will utilize these to when we're moving into advanced cardiology, because one of the things that you look at in a 12 lead is you're getting different snapshots. So it's kind of like if I'm looking at you from this direction and then I went over and I got a side view of you and then I walked around behind you and I got a back view. With lead 2, if it is positive, the QRS is going to be positive and it's a rate. That's just one more piece of evidence to confirm that it's sinus tach.
And then SVT starts at 150, 160, right?
SVT actually, for our purposes in here, because if you get 4 paramedic instructors, they're going to give you 4 different numbers. But for our purposes in here, it starts at 140.
Okay.
All right. Everybody clear on that one? Chase, we're back up to you.
PSVT.
So what is PSVT?
It's when it goes from SVT and then goes back to whatever rhythm it was before that. So
Okay.
sinus.
And or
Would it just be like sinus tag?
so you gave me about half of the definition of PSVT. What's the other half?
Isn't it like you can see it start or stop?
Yeah. So you can see it start and or stop. Okay. Very, very good. Joe. this is a good one.
I'm thinking like a flutter off the bat, but
Can you see identifiable P waves though?
Yeah,
Okay.
that's what we're thinking.
So if you can see identifiable P waves in your rhythm, that eliminates a fib or a flutter.
Because to me, it kind of looks like a 2-to-1 ratio. Because the T wave looks inverted to me. That's just kind of how I'm looking at it.
So I will tell you that's your T wave right there.
Okay.
Here's your T wave. There's your T wave.
Okay.
That's your T wave.
So it has a rate of 150. It looks like. Oh no, 130.
Okay. So we automatically know what about it.
It's tachycardia.
It's a tachycardia. Okay. So now think through the hard drive in your brain of all the different types of tachycardia that we have covered.
Is the PR interval normal or a little longer than normal?
Oh no, you tell me. So if you look at that PR interval, there's your P wave. Don't get misled by that little blip there. And as you compare it, here's your P wave, PR interval. There's your P wave, PR interval. P wave, PR interval. The other thing I'd ask you to look at in this one is the PR interval constant.
No. It looks like it starts longer and then it gets shorter.
I will tell you it does. It varies. So now, tachycardia. Tachycardias that have variable PR intervals. What do you think?
I don't know.
Okay, somebody help him out.
I would say MAT.
Look at that. All right. Why is it MAT, Tanner?
So it's tachycardic, which makes up for the tachycardic part of the name.
Yep.
And multifocal. It's coming from a lot of different spots. So it's a P wave coming from everywhere that's really fast.
Is this rhythm regular or irregular? It's irregular. Why is it irregular? Yeah, but from an anatomical perspective, why is it? Yeah, so we got varying R-to-R intervals. Well, what causes that, Cece?
Is it because the atria is firing in so many different spots and it's just like...
Yeah. So if you think about your atria, here's your heart. Your atria is over here. We've got a spot here that fires and it makes it down to the AV node. Now we've got one that fires closer, makes it down to the AV node. Now maybe we've got one that fires over here from the right ventricle and it takes longer to make it down. So that's what's going to make it irregular. This can look like a flutter, but in a flutter we have big F waves and no P waves, but we can see P waves in here, okay? Sometimes it can look like a fib. Again, we can identify our P waves in there, okay? Good job, Tanner. This next one's yours. A lot of information, but this one should be pretty easy.
I sure hope so. I'm kind of cutting myself off after rate. If they're both being paced at different speeds, would this be third degree heart block? Okay.
Yeah. So this would be third degree heart block. And third degree heart block, remember, atria's doing this thing, it gets down to the AV node, it doesn't get through. Ventricles recognize, hey, we got to do something, so now the ventricles begin pacing at their inherent pacing rate. So that's exactly what it is. Awesome. All right, now, Blake, this is a tough one, okay? Take your time, all right? So don't let me fool you.
Is it normal silence?
got a point.
Please tell me you're joking.
Yeah.
Yeah.
My second guess was asystole.
Okay. Well, let's go with your second guess. So yeah, asystole. Now again, don't get thrown off by there is a little bit of movement on this particular line. That is not VFib. Okay. It's definitely not normal sinus, by the way. But again, we would just simply call this asystole, and nothing is happening. This rhythm is almost always a terminal rhythm, and especially if you see this rhythm in trauma, these patients don't come back. Usually between 1 to 5% get resuscitated. Okay, Teray, hold on. Let me get past this one. This one's yours. I like the fact that you guys are taking your time. You're going to have the 2 full hours for your final exam, so you're going to have plenty of time. So,
Is it second degree type 2?
okay. So she says second degree type 2. It's not second degree type 2. What would you call that? Bella?
Call that a third degree block.
Yeah. So it's third degree block. Let's look and see why. Okay. First of all, we notice we've got more P waves. Let me back up here. We got more P waves than we do QRS complexes. Now, if we were to come in here, now one of the things you got to keep in mind is come back to what Tanner said a while ago. Your atria is firing regularly. Okay. Your ventricles are firing regularly, but they're all doing their own thing. So what we need to do in this situation is we need to find 2 identifiable P waves. I would tell you, let's measure the P to P interval from this one to this one, and then let's work our way back. So we're going to put the edge of our paper on one place, and so let me back up. We're going to put the edge of our paper on this P wave, and we're going to put a hash mark on our paper with this one. And that's going to be our measuring standard. So if we come back here and we put our edge of our paper on this one, where will we find the next P wave? Yeah, it's in the QRS. It's that right there. Okay. How do I know it's there? Look at the other 2. Okay. That's not present. So that is our P wave. All right. If we put our edge of our paper here, it'll line up here, it'll line up here, and moving across, all of our P waves are regular, just like soldiers marching across. Next thing we do, same thing for our R to R. Measure from here to here, and then our next R to R is going to be the same. One of the key things that you will see here with third degree block, you can see it with second degree type 2, but it's very obvious with third degree block, is number 1, your QRS complexes, the rate will be slow. 20 to 40, because remember, that's the inherent pacing rate of the ventricles. All right. The other thing that you'll notice will be, look how wide the QRS complexes are. Why? Because they're being generated from down in the ventricles. With second degree type 2, some of those impulses are still getting through, and that's going to narrow your QRS up. Does that help? Any questions on this one? Juju.
I'm gonna say, well, let me go through it first. So
Good.
versus 80, including the funky looking
Okay.
complexes. There are P waves with the normal looking complexes.
Okay.
As far as the normal looking, okay, so I'm gonna just stop saying normal. I'm gonna say normal sinus rhythm with idioventricular escape beats. Okay, I just get confused on which one has idioventricular.
Okay.
Ventricular escape beats.
No. Go ahead.
PVC.
This is normal sinus rhythm with PVC. So let's take a look.
Yeah, I think so. Okay, I see.
So if you measure your R to R, okay, and then you come back and you compare it over here. Well, this one is early, okay. The other thing we notice here, that's not a P wave. What is that? That's your T wave, okay. This is wide and bizarre looking, as you said, funky looking, all right. And so we know that that's being generated from down in the ventricles, okay. The other thing we notice is what do we call this right here?
Compensatory pause.
Compensatory pause. So that would be normal sinus rhythm with PVCs. Now, what would you call this for the bonus points, Bella?
Normal sinus rhythm with 2 unifocal PVCs.
Yeah, unifocal, which means what? Coming from the same place in the ventricles. Now, let's come back here and let's take just a minute. You called it a ventricular escape beat. Now, here's what you would see if it was a ventricular escape beat. You would see normal QRS. Let's come over here. Normal QRS, normal QRS, normal QRS, and then nothing, 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 nothing. And then you would see that. It would not be early, it would be late. And then you could call that normal sinus rhythm or sinus bradycardia, whatever the underlying rhythm is, with an escape beat. Okay? Good. Bella? I've even given you the answer in the thing. So tell me what that is.
Ventricular tract.
Yeah. I gotta get back in here and fix this. Okay. So yes, I do. So again, everything in here leads to a ventricular oriented rhythm. Okay. All right. See.
Is this a normal sinus rhythm?
Yeah, that's exactly right. It's normal sinus rhythm. Everything is perfectly normal. Okay? All right, let's go through one more round and then I'll let you guys go. All right? If you want to stay behind, if you feel like you need some more help, I'll be here. Juju, I do want to talk to you when we get done with class. No, you're not in trouble. Okay? So relax. All right. Chase, what is that rhythm?
They just give you a ventricular.
Now, why do you call it idioventricular?
No, just regular. Is it just going to be sinus bradycardia?
Yeah, sinus bradycardia. Can't be idiot. Did you say idioventricular? Or?
I was just looking for ventricular rhythms because it was.
Oh, okay. Yeah, look at your QRS. QRS is too normal. You got a P wave, normal, everything. Good recovery. Good recovery. Jump.
The only thing that really sticks out to me is the PR intervals are longer than normal. I can't think of the name. Is it first degree block?
Mm-hmm. Yeah. But now again, if I give you a rhythm, if I give you like this, telling me first degree block is perfectly fine because you have no underlying rhythm to look at. But if I give you an EKG strip, you got to tell me the underlying rhythm. Okay?
For this, if there was an EKG strip, would it be NSR with normal sinus rhythm with first degree block?
Not necessarily because it says the rate is that of the underlying sinus rhythm. Could be sinus tach, could be normal sinus rhythm, could be sinus bradycardia. Okay? Good. Tanner.
Now I want to say torsades, but there was
Stop.
Okay.
Say it.
Is it torsades?
Yeah. Now, what were you going to say?
I remember you told us one time that it was very easy to get torsades and another rhythm mixed up because like that wave motion that they have has to be a certain way.
Yeah, so sometimes torsades and V-fib can be confused. Here's the thing that you're looking at is that this is much more organized. So you see it comes down and you have this ebb and flow. Now, again, that would be torsades. This is much too high of an amplitude to be V-fib, okay? Now, if you tell me this is VTAC, I will count it as incorrect because this is a specific kind of VTAC that you need to be able to identify. Okay? Because we will treat this differently than we will run of the mill VTAC. So that's why I said, I want you started, I want to say torsades. And I said, stop. Okay? Don't talk yourself out of it. Good job. Good. All right. No, Blake.
That would be
Say it again.
V-fib.
V-fib? Why do you call it V-fib?
Oh, I'm sorry. No. It's A-fib because the ventricles are jumped out.
Yeah. Remember, ventricular fibrillation, wide and bizarre QRS complexes. V-fib is usually going to have some sort of regularity to it. This is a type of VTAC, okay, and you can see we do have some regularity to that. But with this one, it is grossly irregular, and we don't have any identifiable P waves. We got some little F waves going on in here, but over in here we have almost nothing occurring. Good recovery. All right, Teray, this one's yours. Accelerate what? Excellent. Yeah, this was a challenge, okay? Because it's easier to look and see accelerated junctional than it is to look at a bunch of words about that. Good job. Very, very good job. So, what makes it accelerated? Anybody? Tanner.
The 60 to 100 beats per minute. Junctional rhythm is usually 40 to 60.
Yeah, so this is faster than its inherent rate. If you call this junctional tachycardia, I'll give you credit for it because it's the same thing. It's a tachycardia because it is faster than the 60 beats a minute. Okay, the best name is accelerated junctional rhythm, but again, junctional tachycardia, I'm okay with. Juju.
There are some QRSs that are dropped, but the PR intervals look consistent.
Ah,
We'll go with second degree type 2.
look at that. Look at that. Yeah, you're exactly right. What's the big problem that we would be concerned about with a patient with a second degree type 2 rhythm? Think back to our discussion on Monday.
Oxygen isn't getting perfused and preload isn't sufficient for
Yeah.
cardiac
Preload is going to drop, which means our cardiac output is going to drop, which means that the heart, the brain, and the kidneys are not going to be perfused. Excellent. Okay. So you see, this one's yours. Okay. I'm going to give you a tricky one.
Is that atrial flutter?
No. Do you see QRSs?
No. Oh, is that a systole?
Is that what?
A systole?
Not a systole. What is this? Anybody? This is VFib. This is VFib. Okay, why is it VFib? All right. It is very chaotic looking. There is no organization. You see no QRS complexes. You see no P waves. You just see a squiggly line moving across through there. Okay. Now, if we had regular QRS complexes embedded in this, then you can make an argument that that was atrial flutter. All right. But with this one, remember, the heart is just kind of sitting there quivering. Nothing is happening. All right. Everybody see why this is VFib? Okay. Electricity is the treatment for this. All right, Bella, this one's yours. If you get it right, everybody gets to go home early. Not, we're going to be here for the next hour or so. It is a junctional rhythm. Is there any real concern about a patient with a junctional rhythm? Tell me more. You're doing maybe not.
Really, there's not like an immediate concern, but long-term junctional rhythm can be a problem.
True. Okay. And again, the thing, I come to both of you. The thing that we're looking at here with this is treat your patient, not the monitor. Okay. If your patient's having chest pain and they're in junctional rhythm, yes, we are concerned. And you're exactly right. Long term, that it tells us that there's something going on higher up in the the atria, and especially with the SA node, that should be firing. Okay. But if you got a patient who's laying there, they got a good blood pressure, good color, maybe they're talking about a little bit of fatigue, and that's it, and we'll watch our patient really, really closely. Blake.
Oh, I just said depends on if the patient's symptomatic.
Yeah. Always treat your patient, not your monitor. Bella. Awesome. Okay. All right, guys. That's your review. Now, we've covered the different words that you need to know on your study guide. But again, 75% of your final exam will be rhythm strips or definitions just like this. Yes?
Are these going to be posted at all on Blackboard?
I will post these later on today so that you can go back and look at them. Yeah, I don't have a problem with that. Anybody else? All right. Go do something for yourself today. All right. Teray, give me about 15 minutes and we can move up our advising appointment. We'll get you taken care of if you still want to. And so everybody have a good day.